Today, we're going to examine the question of normal aging, and we want to review some of the basic principles on the biology and physiology of aging that have clinical implications for both clinical assessments and for healthy longevity. We're reminded of this poem by T.S. Eliot with each patient encounter. I've lost my sight, smell, hearing, taste, and touch. How should I use them for your closer contact? This reminds us of the neurosensory impairments that older adults have. Often, our communication has to be guided by an appreciation for the fact that older adults may have hearing impairment as well as visual impairment. The goals today are to look at aging demographics. We want to briefly look at theories on aging that are helping inform gerobioscience, and we want to be able to distinguish normative aging from disease in old age. It used to be that people thought memory loss was a normal part of aging. It wasn't until scientists and clinicians gave that condition a name, Alzheimer's disease, that people actually understood it to be a disease rather than a normal process of aging. Some people say that aging is not a disease, and that's a good understanding of how we should view the older adult population. 30 years ago, people thought that aging was irreversible. Over the years, research has shown that aging actually can be stopped and possibly reversed. This perspective has changed considerably. In the left column, we see the traditional view that aging is an inevitable process of biological breakdown. It's cumulative and irreversible. The approach is to ameliorate aging problems with medications and pain control. It's a very disease-oriented process. On the right-hand column, the question becomes that if we slow the aging process or stop it through a variety of means, which may include things like plant medicinals in combination with biologics, by slowing the rate of aging, even that we may be able to prevent age-related diseases. The converse of this is to think about something like diabetes, which is an aging accelerant. It would be true that a lot of the age-dependent diseases are more often seen in the diabetic population than in the non-diabetic population. Now, we see both ends of the spectrum of how there may be populations of older adults that have accelerated aging, and those that have a slower rate of aging. The question is, what can we do to mitigate the rate of aging? We'll offer you some ideas as we move along. Some common principles. One is that there's a disconnect between your biologic age and your chronologic age. Recent research shows that dramatic situation in terms of some of the population being older than they actually think they are. Some of the individuals in a population actually being younger than their chronologic age from a biologic perspective. The other point is that organs age at different rates. The most impressive example is the involution of the thymus gland where, by the age of 20, the thymus gland is fully involuted and the immune system has been established. Therefore, other organs, such as the brain, do not age at quite the same rate. Other organs, such as the liver, have regenerative capacity. The brain has neuroplasticity and regenerative capacity, but at a very different level than the liver. The other principle that we alluded to earlier was that the rate of aging can be slowed and reversed. We'll talk a little bit about some research that supports that point of view. Here we see a study where everybody is the same age. They're 38 years old. Their biologic age was calculated by a panel of measurements, which includes blood pressure, centripetal circumference, monocyte count, telomere length, and a variety of other measurements. That gives this composite score that represents a biologic age. It's a bell-shaped curve. Half the population at the age of 38 is older than 38, and half is younger. The question is, what causes this variation? You might also consider the fact that as we get older, 65 and older, the variation in our biologic age increases even more dramatically. That bell-shaped curve starts to flatten out or distribute it more. The more recent conceptualization that 70 is the new 60 in terms of age might have some relevance as the population is aging and living longer with each year. It just reminds us of what kinds of things we can do as a population, as well as individuals, to enhance or extend that healthy lifespan. If you look at people that are to the right of the dotted line on this curve, what kinds of things can we prescribe for them that will move them to the left of that dotted line of 38 years old? Physical activity and nutrition would be two examples, and there might also be some chemotherapeutics that we can discuss as part of a research protocol that might influence that curve to the left. Estimate the ages of these three women seen here on the slide. Surprisingly, these women look younger than their stated age. This is an important concept clinically. When you do see a patient, when you see them to be younger than their stated age, or perhaps older than their stated age, research has shown that this is a pretty good barometer or metric for their biologic age. Clinical encounters need to include a statement as to whether the patient on physical exam looks older or younger than their stated age. We've established that patterns of aging vary from person to person. We want to talk about the genetic component as well as the environmental component. Think for a moment how much genetics play a role in healthy longevity. When asked this question, many people respond by saying 50% or 80% of your healthy longevity is associated with your genes research. Actually, it shows just the opposite, that the genetic component to your healthy lifespan perhaps is only 10 to 25% contribution, in that most of the healthy lifespan is due to environmental considerations. These include exposure to toxins and accumulated toxicity, as well as our habits that include physical activity and proper nutrition. For example, in the Adventist study, those who were vegetarian typically lived 6 to 10 years longer than other people in the study who were omnivores. Choices that we make over our lifespan may influence our longevity. Here's a pictorial or a cartoon display of what we're trying to accomplish. At the left side is early life, and over time, we can see that there's a progression of the population or an individual towards lower functionality. Eventually, the end point of death is geriatric-focused individuals. We want to keep everybody above this dotted line. We want to maintain as much functionality as possible. To do so, through mostly prevention measures, some of these treatment measures may over time, as we'll see, creep up into this higher category, such as a chemoprophylaxis for senescent cell removal from your tissue. When we look at the definition of aging, it would be fair to say that it is the sum of all changes that occur with the passage of time and importantly leads to functional impairment. If anybody ever asks you what the difference is between geriatrics and usual healthcare, the highlighted functional impairment is the key answer. Over the last decade, we had unprecedented growth in the aging demographics. Some people call this the silver tsunami. Here are some population graphs that you can see starting from the 1960s to the 1990s through 2020. This is called the rectilinearization of the curve. You can see the baby boomers there in pink marching on up and contributing now up to 18%, soon to be 20% of the overall population in the United States. Here's a distribution map by county that shows where older folks are located, up to 33% in some of these dark and blue areas. You can see both on the Canadian border and through the central and rural parts of the Great Plains. Consistently throughout the country is where the oldest reside. Not surprisingly, these are the individuals that have the least resources to manage functional impairments as they get older. It poses a really big question in terms of what can be done to help these individuals age in place. Overall, we understand aging and life expectancy to increase over time. This is a somewhat older graph and projection, but it illustrates the point that both women and men have a higher life expectancy. Individuals, for example, at the age of 85 will have 5 to 6 more years of life expectancy. This is absolute life expectancy until the time of death. This does not talk about functional life expectancy. Functional life expectancy goes hand in hand with absolute life expectancy, but there's a difference of about 2 to 3 years between the two. In other words, if your absolute life expectancy is 91, you will spend 2 years prior to your death in some form of functional disability or impairment. This is the window that we're concerned about in particular in geriatrics, as to how to deal with those 2 to 3 years of final life expectancy that are associated with some sort of functional impairment. Functional impairment being defined by measurements such as loss of an activity of daily living, such as grooming or needing assistance with bathing, but it also might be more subtle, such as the inability to go grocery shopping, or perhaps problems with finances or paying bills. With theories on aging, you can see a list here. All of them have credibility. No one theory accounts for everything. There is the immunologic theory of aging put forth by Dr. Roy Walford, a pathologist from UCLA. He was a big proponent of caloric restriction for enhancing healthy longevity. He was quite a thin man and ate very little. In 2023, the hallmarks of aging were updated from 9 to 12, providing a comprehensive framework for understanding aging as a modifiable process. This shift emphasizes targetable pathways like autophagy and inflammation, opening doors for therapies that could extend health span by addressing root causes rather than symptoms. Some of the other theories that we want to talk about that seem to have some importance is the mitochondrial theory. Researchers have found that mitochondria of DNA mutations occur at a much faster rate than nuclear mutations, thus posing the mitochondria to be age-related dysfunction. There's a lot of evidence that show these mitochondria do not produce energy as much, and in fact, there was an article, somewhat recently, that showed one carbon metabolism is defective in T cells from aged donors. That defect can be compensated for or reversed by glycine and formate supplementation. That needs to be investigated clinically, but it may offer some possible insights for clinically translating some observations that have been made in the biology of aging. One of the other points on the mitochondrial theory is that reactive oxygen species injury also increase, and as a consequence there's an increase in accumulated damage, particularly with proteins that start to cross-link, are damaged and become dysfunctional. This leads to an increased susceptibility to cell death and programmed cell death called apoptosis. Recent 2024 to 2025 research highlights NAD+ precursors like NMN as promising interventions to combat mitochondrial decline, potentially reversing energy loss and ROS damage. Clinical trials show benefits for age-related diseases, aligning with the goal of preserving organ function. Telomere theory got a lot of attention about a decade ago. These are the end plates of the telomere that shorten. They're seen when cells sequentially divide in a cell culture. They start to lose their replication capacity. They become inert, and if you measure these telomeres at the tips, they become very short. Part of the reason is the enzyme that puts those end points and maintains them. Its activity decreases with increasing age. Now, certain conditions of disease can impact telomere length. For example, HIV-infected individuals tend to have shortened telomeres compared to age-matched controls. People who are sedentary or obese have shorter telomeres than those who are active now. The good news is that if you increase your physical activity, you can put a little bit more length into your telomere. It is a reversible process. This is one of the reasons that we would want to advocate increased physical activity and to reduce obesity for impacting biologic aging. The other thought in theories on aging is that transposons get disrupted, leading to genomic instability. There's also some thoughts that the methylation of protein around the DNA and the DNA itself becomes altered. This has been true in most cases in studies. It's not clear that those changes in the DNA affect relevant genes for everyday metabolism and functionality. A lot of these changes occur in what we call inert or non-transcription active DNA. Dysbiosis, added as a 2023 hallmark, links gut changes to systemic aging. 2024 innovations like CRISPR-guided microbiome editing could restore balance, offering a novel way to mitigate age-related diseases like frailty. Clinically, this supports probiotics or fecal transplants for longevity. A recent theory proposed by Dr. Horowitz is that there's an epigenetic clock. There is a DNA methylation that increases with increasing time, and you can predict somebody's age based upon this methylation clock. This has gained a lot of attention, but again, this relates to the whole question of what impact does it have on transcription and transcriptional activity. That would be important for the aging process, and that has not yet been established. From 2023 to 2025, AI has revolutionized epigenetic clocks by using deep learning on data like echocardiograms or facial scans to predict aging risks. This allows personalized interventions, such as early lifestyle changes, to slow biological aging and prevent diseases like heart failure. Another important theory is called error catastrophe. This is where there are damages to protein that include cross-linkage. Diabetes is a good example of what we age generated in products, or another name for the person who discovered them, Amadori products. These are covalent cross-linkages between glucose and the peptides. You get these cross-linking events that cause protein aggregates, and in some cases, people believe that it causes what we call proteotoxicity. These aggregates of protein actually become toxic to the cells. Studies from 2023 to 2025 show partial reprogramming with Yamanaka factors can rewind the epigenetic clock, reducing proteotoxicity and aggregates. This has clinical potential for rejuvenating tissues, but safety trials are ongoing to avoid risks like tumorigenesis. An additional theory we had mentioned is immunosenescence. Typically, the T-cell memory cells, in particular, accumulate as you would expect with aging, and the native T-cell subset starts to decline. Those native T-cells are less able to be activated under circumstances of infections. Sometimes they get dysregulated and cause autoimmune-type reactions. Most of the aging immune system is within the T-cell branch. Although more recently, research has shown that there are some defects in the B-cell progenitor cells, and that macrophages and monocytes are also defective. There is new emerging evidence that these monocytes and neutrophils migrate to inflamed tissue and send out inflammatory signals that are sustained. While the overall impression is that the immune system is slow to get activated in older adults, once it is activated, it may produce a cytokinin storm that is perhaps not reversible. More recently, with the pandemic with COVID, the cytostorm is one of the indicators of bad outcomes, and the older adults are the ones that are succumbing to the pneumonitis, more so than younger individuals. One of the mechanisms may be the cytokinin storm. Inflammaging, formalized in 2023, explains sustained inflammation in aging. Recent clinical perspectives from 2024 to 2025 emphasize drugs to clear it, improving outcomes in conditions like arthritis or neurodegeneration, key for maintaining immune balance in older adults. The aging process can be viewed as a functional impairment over time. One of the goals that we're trying to achieve is to keep everybody 100% highly functional. You can see that in an average population, functionality over that population declines as they reach their life expectancy. Some people, such as diabetics, maybe alcoholics, maybe substance abusers, will have an accelerated loss of function. Conversely, people who are successful agers, if you will have a slower onset and amount of functional disability. We want to move the curve here from red to blue. That's one of our goals. Certainly, through behavioral and lifestyle interventions, try to move this green curve over to the red curve. Organs age at different rates. Their manifestations, as we see, in the older adult are as displayed here. We know that kidney and heart function are the most susceptible to age-related processes. Other things, such as physiologic changes in body temperature, really don't occur so much. If you see somebody with a lower basal body temperature, let's say 96 degrees Fahrenheit, you might want to consider that in the context of hypothyroidism or other reasons for a lower resting body temperature, as opposed to blaming it on age per se. Next, we'll discuss organ-specific aging. Here we'd like to go from organ to organ, a tour of what aging does to the organs. With the aging eye, we know that there's increased iris rigidity. The pupil may be sluggish, dilating, and accommodating. This actually becomes a problem with light to dark adaptation, where people, after they see a bright light in the older adult population, may have temporary blindness for a longer period of time than the younger population. Of course, there's cataracts that occur with increasing age, sometimes accelerated by certain occupations, such as sailors and fishermen who have the reflected UV light off the water that accelerates cataract formation. There's syneresis, which occurs because of the vitreous contracts. Those are floaters that we talk about, little spots that we see floating across the eye. You'll see less of a foveal, that so-called red light, reflex as people get older. Here's what it looks like to see through eyes that have cataracts. With glaucoma, you can see on the retinal exam the increased cup-to-disc ratio and the so-called nasalization of blood vessels. You can see here there's a visual impairment. The peripheral vision is reduced substantially. There's also senile macular degeneration. There's the so-called wet exudative of senile macular degeneration versus the dry, which is more prevalent. Central vision becomes blurred with people with senile macular degeneration. There are auditory changes with age. With increasing age, at least up to half of the population has hearing impairment. This occurs insidiously. People don't always recognize that they're having hearing loss, and sometimes they'll blame their spouse for not speaking clearly enough, loudly enough, or mumbling. Those may all be indicators that the individual is having reduced hearing. Now, here's our first polling question for you to consider. By what age does at least half the population experience hearing impairment? A. 60. B. 70. C. 80. Or D. 90. The correct answer is C. 80. The prototypical audiometrogram is shown here on the left. This represents presbycusis, which is the loss of hearing at high frequencies. You can see in the upper part of the graph, the x-axis, that 4,000 to 8,000 Hz requires very loud conveyance of those frequencies for people to hear them. Sometimes, the hearing impairment is compounded by serum impaction. It's absolutely mandatory with each clinical encounter that the older adult have their ears examined, both in terms of a hearing test, as well as for serum impaction. Presbycusis is the result of bilateral high-frequency hearing loss. It's insidious, and it's recognized when the hearing acuity dips below 8,000 Hz. Sometimes it is associated with ringing in the ears or tinnitus. There is a gender difference where men experience more hearing loss than women. You should also consider hypothyroidism as one of the reasons why hearing loss might occur in the older adult population. There are consequences for presbycusis. There's deterioration in communication. Sometimes people feel more isolated. Family members and friends may consider the person senile as a result of hearing loss. All this leads to increased depressive symptoms, sometimes even paranoia. They're talking about me. Also, further functional impairment related to this is withdrawal from social activity. With the aging mouth, dry mouth can be accompanied with dry eyes, but the impact of this is not so much with aging, but rather with medications that reduce salivary flow. Typically, these are anticholinergic medications, which are generally a no-no in the older adult population. A prototypical medication that's commonly used is Benadryl diphenhydramine. This medication is highly drying, anticholinergic, and can cause confusional states in older adults, as well as this general phenomenon of drying the mucosal membranes. There are neurologic and cognitive changes with aging. We will be covering the central nervous system through the peripheral nervous system and the autonomic nervous system. Cerebral blood perfusion generally declines with increasing age. We haven't quite put together the functional consequence of that. Low perfusion does not always necessarily mean less brain function, but there are studies that are looking at both function of the brain as well as brain volume, particularly hippocampal volume as a proxy measure for Alzheimer's dementia. Progressive loss of hippocampal volume has been linked to Alzheimer's disease, and interestingly, some research shows that individuals on a Mediterranean diet, particularly those supplemented with fish, have a lower rate of hippocampal shrinkage over a 5-year period than when compared to people that are on a more diverse omnivore-type diet. There's some subtle changes with memory and aging. These are typically called tip-of-the-tongue word searches. People try and think of a particular word and just can't recall it. This can be seen with aging, but for the most part, the acquisition of memory is a little bit slower with aging, but it is not defective. This is a study that was done by John Disterhoft many years ago. It shows a Pavlovian conditioned response, where he took an eye blink, a puff of air in the eye, and coupled it with a ding sound. He eventually got rid of the puff, and people still blinked with the sound over a period of time. As you can see, that blinking started to extinguish after so many repetitions. One of the rate of extinction was at a certain rate for younger people and was fairly quick, where it took longer for the older people to extinguish that reflex. There was an interesting study from Finland where they compared older adults with young adults, trying to memorize their mini golf score. A little bit of physical activity with memorization. The young and old had equal abilities to remember their scores without auditory distraction, but once there was some loud music interjected, the older people had less memory retention as a result of that distraction. Notice some research on the autonomic nervous system changes with age. In the right graph, we see the loss of sympathetic tone over time with age. This is a cross-sectional study, but you can see there's a steady decline in the sympathetic tone, whereas the parasympathetic tone in a cross-sectional study appears to have a U-shaped curve, where folks that are 85 and older tend to have a parasympathetic footprint, similar to those that are in their 40s and 50s. The relevance of this is not clear. It's not clear really whether these individuals with high parasympathetic tone started off with high parasympathetic tone when they were younger, or whether they just sustained it or actually improved it through different measures. What kind of measures could they take? Those would be physical activity, mindfulness, and certainly meditation, which improves parasympathetic tone. The other observation that was implied by those graphs is that heart rate variability decreases with age. If it goes down, those are beat-to-beat variations. There are several studies that show that with more than one standard deviation compared to your age and match control, that low heart rate variability is actually a predictor of mortality. So you have a twofold mortality rate with low heart rate variability. Again, things that can enhance heart rate variability are those things that help slow the heart rate down overall. A slower heart rate has more variation. Things like physical activity will slow the heart rate down, which seems to have the most impressive impact on trying to reduce heart rate and trying to improve heart rate variability. We know that the environment has an impact on heart rate variability. This is an example from a study that showed when ambient particulate matter and air pollution accumulates, the heart rate variability in older adults declines dramatically. That may account for one of the reasons why highly polluted areas, heat stroke, which causes a lot more, or heat waves cause a lot more ambient particulate matter. Part of the reason or the mechanism by which older adults succumb during heat waves. Let's talk about the heart and aging. As we get older, a third to a half of the population has high systolic blood pressure. Certainly, a third of all 65-year-olds will have high blood pressure by the time they reach 80. If they do reach 80, 70% of them will have systolic hypertension. Part of the aging heart is that diastolic relaxation declines. The aging heart is not able to accept as much blood as the younger heart. In some cases, that problem with diastolic relaxation results in diastolic heart failure. There's also a decline in the refractory period by which the heart recovers and creates the squeeze to push the blood out. Associated with the aging heart is the aging respiratory system. There's this concept of senile emphysema where the alveoli enlarge. They're not destroyed, they just become more bulbous. As a result, there's less surface tension and less recoil. Interestingly, there is some that show there's an increased migration of macrophages. Part of this may be due to the accumulation of what we call the senescent cell phenotype. These are large fibroblasts that reside in tissue. They no longer have replicative potential, but they tend to exude inflammatory signals, thereby potentially increasing and recruiting more macrophages into the system. That may be one of the theories behind the so-called cytokinin storm that occurs with aging. Here's a table of different pulmonary changes. The FEV1 forced expiratory volume in 1 second declines with age. The VQ inequalities, lower ventilation in the lower half of the lungs. For that reason, we want people as they get older to be sitting up rather than lying down for optimal gas exchange. Here's an example of the FEV1 declining with age. Interestingly, there are some old people that look young and some young people that look old. There's again variation in lung function. As you look at a population from age group to age group here from 25 years old to 75. With these pulmonary changes with age, the older adult, increasing age up to 80, the average pulse ox declines, and so they become closer and closer to a hypoxemic state. The clinical implications are that you get potential atelectasis that promotes hypoxia, as well as pneumonia. That's why deep breathing exercises are important. The alveolar mismatch with the blood is exaggerated in the supine position. So, we want to try to promote upright positioning in deep breathing exercises. Here's a study from Britain. This is a 2008 study published in the British Medical Journal that showed what happens when middle-aged smokers are told their age-equivalent lung function. For example, telling a 50-year-old smoker that they have the lungs of a 75-year-old. By stopping smoking, they can delay this course of lung deterioration. During the study, it was found that 40% of them decided to stop smoking, as opposed to the traditional methodology of the physician or provider wagging their finger at them and telling them to stop smoking, which only accomplishes about a 10% cessation rate. This is one of the cases where ageism is used beneficially to change smoking habits. Our graph here demonstrates what we were talking about on the previous slide. The supine position exaggerates decreases in PO2 and hypoxemia. We get a green star, as opposed to a gold star, for keeping our older adults up and moving around. With lung aging, there's a steady increase in cancer with age, obviously compounded by secondary smoke and primary smoking. Moving on to the gut with aging, we mentioned that dry mouth is a problem in quite a few older adults. This can lead to exaggerated problems with dentition, dengal recess, and tenderness. If somebody's starting to lose weight in the older adult population, the first thing to do is look at the dentition, look for pain, particularly in older adults with cognitive impairment who may not be able to express problems with eating. 10% of us actually have some form of silent aspiration, but because of the reduced oral to pharyngeal phase of pushing the bolus into the esophagus, that silent aspiration can increase up to a third of the population who are 90 and older. You can see as a consequence of age that by the time you're 100, you're at a 100% chance of aspirating, and that all comes from this dyskinesia that occurs in the oral pharynx. Some of the key features that we need to think about in normative aging with the gut is that there are reduced contractions, less peristalsis, decreased acid clearance, which predisposes people to gastritis, particularly with the NSAIDs. One of the big points to make is the reduced antral volume. This leads to early satiation. Clinically and practically speaking, it has some implications. For instance, if you provide protein dietary liquid protein supplementation with each meal, that high protein load is going to cause early satiation, and older adults will not consume a full regular meal. As a consequence, we often in geriatrics encourage people to take protein liquid supplement in between meals rather than with their meal. There's an issue with acid clearance. There's certainly normal acid secretion with age. One of the things that we notice with the aging gut is that there's an increase in reflux. Part of that may be related to the 30% of the aging population that's obese, as well as for other reasons. But one of the implications for this is that there's an awful lot of proton pump inhibitor prescription, as well as H2 blocker prescriptions. More recently, Zantac was taken off of the market because of contaminants that are highly carcinogenic. There's a movement afoot to reduce proton pump inhibitor use long-term in the older adult population for two reasons. One is that proton pump inhibitors predispose older adults to accelerated osteoporosis. And secondly, it predisposes them to C. diff colitis if they are on antibiotics. With other issues with intestinal aging, there's some minor changes in the small bowel, so there might be a little higher population with lactose intolerance. Somebody that comes into the clinic and talks about loose bowels or diarrhea, you might consider lactase deficiency as your first line of thinking. There's also a higher incidence of bacterial overgrowth, leading to decreased B12 absorption, as well as folate. Recent articles showed that diabetics in particular are most susceptible to folate deficiency. To emphasize the dreaded fecal impaction, there's a lot of reasons for this occurring with age. But in your review of systems, it's so important to find out when the last bowel movement occurred. If somebody tells you 2 to 3 days ago, that could be an issue, particularly if they have a confusional state. If they are in that confusional state, it can report problems with their bowels, because in one study, up to 40% of delirium, or acute confusional state in older adults, was attributed to either fecal impaction or obstipation. Musculoskeletal changes with age. We need to think about who are you comparing it to. Are these unconditioned versus those that regularly exercise? There is a steady 1% loss of lean muscle mass per year after the age of 65. For our second polling question, we'd like to know, what is the approximate annual rate of lean muscle mass loss after age 65? A. 0.5%. B. 1%. C. 2%. Or D. 3%. The correct answer is B. 1%. Here are age graphs going up to 100. You can see the steady decline in both arm strength and grip strength. We actually recently published an article with Dr. McGrath that looked at asymmetry of grip strength as a proxy measure for functional disability in the older adults. Because of the steady march of muscle mass loss with aging, it is so important to prescribe resistance training in the older adult. No matter what the age, there was a Dr. Fattori study many years ago that showed that even 90-year-olds can benefit from resistance training minimally twice weekly for 30 minutes. The clinical implications of the aging muscle is that we get this concept of sarcopenia or dynapenia, where you get both muscle mass loss as well as overall weakness of the remaining muscle. As a consequence of that, a lot of people are unable to do very small minor lifting. They have problems with their daily tasks. When you say somebody has problems transferring from the bathtub or shower back to the bedroom, that's in part because of this loss of muscle mass. Be mindful of the fact that hospitalization is the biggest risk factor for loss of muscle mass. There's actually an epidemic of sedentariness in the older adult population that is hospitalized. Mesenchymal stem cell, MSC, rejuvenation research from 2023 to 2025 shows they can reverse muscle aging by reducing inflammation and promoting regeneration. Clinically, this could treat sarcopenia via infusions, extending functional mobility. Trials are exploring combinations with exercise for optimal longevity. Here's an example where physical activity prevents functional decline in older women. Exercise improves active life expectancy, and remember, active life expectancy is that period of time with preserved functional status. With skin and integument, some of this might be self-evident in terms of epidermal thinning. As people get older, they become more homebound, less likely to be outside, and they get low vitamin D levels. Here's 6 different pictures for common conditions in older adults, which is herpes zoster. Take a look and see which of these pictures you think most represents the grape-like clusters of shingles. If you had picked item 4, it's the slide that is most representative of zoster. You can see there's a little grape-like macule papules with an iriditas base, which is different than herpes or impetigo, which is more confluent, as opposed to insect bites, which are spaced in somewhat a random fashion, but not in a cluster of grapes. Zoster increases with increasing age. One of the interventions is to have the shingles vaccination for older adults. At least 33% of shingles occurs on the face, and of that 50% is associated with eye involvement. You'll have both reduced vision, if not the worst, and extreme case of total loss of vision. Vaccination needs to be emphasized for those that are reluctant to do so. Let's talk about nutrition and longevity. With the Adventist study, the extra years of life expectancy gained by a vegetarian-forward diet is quite dramatic. Those that have vegetarian with milk and eggs get intermediate benefit. But this really drove home the concept of you are what you eat. That along with this improvement, there is increased functionality in the older adult population. It may not be based on this study. It may not come as a surprise that Loma Linda, which has a high concentration of practicing Adventists, have an exceptionally high longevity. They're considered a longevity zone in the world along with Okinawa, Costa Rica, and an island in Italy called Sardinia. Telomere length can be altered by aging and inactivity. The good news is that by becoming more active, the telomere length can be rejuvenated. Physical activity is an important intervention. Most of the studies are showing that more is better. A recent study demonstrated that 8,000 steps per day is associated with an overall reduced mortality by 50% in people that accomplish 8,000 steps a day or more. There's other studies that show reducing cardiovascular risk factors are improved dramatically with longer duration of physical activity and higher intensity. More is better. You get 10 to 20% reduced cardiovascular risk with moderate activity. If you go to 90 minutes with high intensity, you get up to a 40% decreased mortality risk. Our current odds of living to 100 are about 1 in 4,000. We might be able to influence that royal flush goal by improving our diet and physical activity. This ratio is going to change, so children that are born currently will have a 1 in 100 chance of living to 100. We really do need to prepare ourselves and our healthcare system for dealing with the fastest aging group, which is the 100-year-old and older population. Today, we're reviewing a case on addressing the biology of aging in geriatrics, featuring Mrs. F., an 82-year-old widow presenting with fatigue, mild hearing loss, reduced grip strength, unable to open jars, and early satiation causing weight loss. Chronological age, 82. Biological age estimate, via metrics like BP and telomere length proxy, approximately 88. No major diseases, but family history of longevity. Assessment, the patient's sensory exam shows presbycusis, high-frequency loss, and xerostomia, dry mouth from medications. Musculoskeletal evaluation reveals 15% below-age muscle mass, sarcopenia. GI review notes reduced antral volume, contributing to malnutrition. Cardiovascular assessment shows low heart rate variability, with systolic BP 145 mm per mercury. Interventions. For lifestyle, Mrs. F was prescribed twice-weekly resistance training, 30 minutes, and 8,000 daily steps to combat dinopenia and improve HRV, per studies showing 40 to 50% mortality risk reduction. With nutrition, she was advised to shift to Mediterranean vegetarian diet with between-meal protein supplements, vitamin D for skin thinning or hypovitaminosis. For medical, she had hearing aid fitting. Anticholinergics were deprescribed to reduce dry mouth. She will be monitored for silent aspiration. Outcome. After 6 months, grip strength improved 20%, weight stabilized, and self-reported isolation decreased. Functional longevity was extended. Mrs. F regained independence in daily tasks, illustrating how targeting aging biology prevents decline. In summary, we talked today about the demographics that show a population explosion in older adults. We looked at what we consider normative aging and how that might help us clinically. We also know that not everybody at the same age looks alike from an age lens. We need to address their function rather than their age as we make clinical decisions. One of our goals clinically and through health promotion is to preserve, if not extend, functional longevity. If it's not your issue, it certainly will be. Thank you.